Hi all, in this video we're going to see about hemoglobinopathies. So the two most important hemoglobinopathies that you should know of is sickle cell anemia and thalassemia. So we'll concentrate more on these two types of hemoglobinopathies. So the questions that can be asked from this part are either as a part of a structured essay or as a short essay question or physiological basis question or even as a part of your MCQ questions. So we'll see more about each. So we know that hemoglobin can be of two types. There can be normal hemoglobin as well as abnormal hemoglobin. So when we say normal hemoglobin, we mean our hemoglobin A, which is a adult hemoglobin which contains 2 alpha and 2 beta chains. Then we've got hemoglobin A2 which contains 2 alpha and 2 delta chains. Then we've got hemoglobin F, that is a fetal hemoglobin which contains 2 alpha and 2 gamma chains. And in the fetal period you can also have small amounts of BART hemoglobin which contains 4 gamma chains. Now we also know that there are embryonic hemoglobin which is present during the embryonic time. So they include the Gower hemoglobin 1 which contains 2 zeta and 2 epsilon chains. Then we've got Gower 2 which contains 2 alpha and 2 epsilon chains. And we've got Portland hemoglobin which contains 2 zeta and 2 gamma chains. So I'm just mentioning this because you can expect one word questions from this part. Which are the different embryonic hemoglobin, which are the different fetal hemoglobin, which is the normal adult hemoglobin, and you should know the globin chains that are present in each. Okay. So abnormal hemoglobin, of which the most important is sickle hemoglobin, that is hemoglobin S. It is mainly present in sickle cell anemia. And what's the difference between this sickle hemoglobin or HbS and our normal hemoglobin HbA? The difference is that in sickle cell or sickle hemoglobin or HbS, we've got valine instead of the glutamic acid in the 6th position of the beta chain. So as I said before, a normal hemoglobin contains 2 alpha and 2 beta chains. So on the beta chain in the 6th position originally we have glutamic acid. Okay, so that is why you've got normal shape for the RBCs. But in sickle cell, what happens is, instead of this adenine here, we've got thymine, which means now instead of glutamic acid, it is going to code for valine. So in the 6% of the beta chain, we've got valine instead of glutamic acid. Thus, you've got this sickle hemoglobin. So the change is in the 6th position of the beta chain, wherein you've got valine instead of glutamic acid. This is a very important question and can be asked in your multiple choice question, your NEET PG exams. It's a very important point. Okay. So because of this HbS, the shape of the RBC becomes sickle shape. That is why it is called sickle cell anemia. So sickle cell disease is inherited as an autosomal recessive trait. So we know that the main problem of sickle cell anemia is that the shape of the RBC is changed. But why is it changed? Well, that is because these RBCs which contain HbS, once it is exposed to low oxygen tension or low pH, it precipitates into crystals within these RBCs. And these crystals will elongate so that the shape of the RBC will be changed. Okay. So HbS is less soluble, so precipitate into crystals within these RBCs under low oxygen tension or low pH, and thus these crystals elongate, changing the shell shape from biconcave to sickle shape. So this is a problem with HbS or sickled hemoglobin. So what is the problem of having these sickle shape RBCs? The problem is that it can cause obstruction to flow, which in turn can lead to increased blood viscosity and thereby decreased blood flow to the tissues. And not only that, these sickle cells are more fragile, so they're more prone to hemolysis, and thus you can have sickle cell anemia. Now, one good thing about this HbS is that those individuals who have sickle cell trait, which means they've got some amount of sickle cell disease, so such individuals, they have resistance to malaria. Why do they have resistance to malaria? Because this germ that is causing malaria, the organism that is causing malaria, they can survive only in proper biconcave shaped RBC. They cannot survive in a sickle shaped RBC. That is why individuals who've got sickle cell anemia, they've got resistance to malaria. Okay, so this blue colored thing is that plasmodium which causes malaria. As you can see, it needs this It's sort of a ring-like structure. So it needs this biconcave shape of the RBC to survive. It cannot survive in a sickle shape RBC. Okay. So now we'll see what are the clinical features or the pathophysiology of what happens when there is sickling of RBC. So as I said before, in sickle cell disease you've got sickled RBC, and because of that you've got vaso-occlusion. Because the shape is sickled, there can be obstruction to the blood flow. Now this obstruction to the blood flow can occur at any organ. Okay, so that can be blockage of arteries and lead to decreased oxygenation of the organs or tissues. So based on the organ that is affected, the symptom will also change. So for example, if there is the blood supply to a bone is affected, it can cause severe pain in that area. And suppose it is an extremity like fingertips that is affected. If the blood flow to the fingertips or toes are affected, you can have dactylitis. You can have severe pain in that infracted area of bone. Now sometimes it can occur in the spleen also. So you can have splenic infarction, and because of splenic infarction you can have sepsis and meningitis, because spleen is an area which filters out a lot of germs. So when spleen is not there, you can have sepsis and meningitis. And it can also cause vaso-occlusion of other arteries. For example, it can cause vaso-occlusion of the cerebral arteries, which causes stroke, of the kidneys, which can cause renal failure. So these are the problems of blockage of arteries. Now, when the blood flow is obstructed, it need not be obstruction of arteries alone. There can be obstruction of the veins also. So there can be blockage of venous outflow. Now this can cause occlusion of the vessels in the lung, which can produce a symptom called acute chest syndrome. Okay, and it can also block the venous outflow spleen, causing splenic sequestration. So these are the symptoms of or clinical features of sickle cell disease. So you can have this vaso-occlusive crisis, which includes this pain crisis, dactylitis, sepsis, meningitis, stroke, renal failure. You can also have this acute chest syndrome and splenic sequestration. So thus, if I am going to diagrammatically represent the clinical features, you can draw like diagram like this, and you can have painful occlusive crisis whenever the supply to the bones are affected. You can have features like stroke if the cerebral arteries are affected. You can have sickle chest syndrome or acute chest syndrome due to the occlusion of venous outflow. And you can have splenic sequestration, also called sequestration crisis. What are the different precipitating factors? See, we said that it is low oxygen tension and low pH that will cause this polymerization of hemoglobin, causing sickling. So thus in all conditions that can produce hypoxia, acidosis, dehydration and infection, they all can trigger the sickling, leading on to the crisis situation. So what are the different investigations that you can do to prove that it is sickle cell anemia? So we know that the basic pathology is that the RBCs are sickled. So you can take a peripheral smear, and in that you can see these sickle shaped cells on the peripheral smear. Not only that, we know the sickle cells are very fragile, which means there is a lot of hemolysis. So whenever there is hemolysis, you can have anemia, which is normocytic anemia. So you can get that also in the peripheral smear. So whenever there is increased destruction of RBC, we know that there is increased marrow erythropoiesis to compensate for that, which means there can be reticulocytosis also in the peripheral smear. Now, apart from peripheral smear, because of this increased hemolysis, you can also have increased unconjugated bilirubin released, which in turn can cause jaundice as well as gallstones. So when we check the bilirubin levels, you can see that it might be increased. So based on this, we will now enumerate the different investigations that you can do. So the first is, of course, you can check the hemoglobin and it will be decreased. You can take a smear, and in the blood picture you will see this normocytic anemia, sickle cells and target cells will be visible. So these are the sickle shaped cells, right? And target cells is another feature of uh, anemia, wherein you can see there will be a dot inside this RBC. You can also have reticulocytosis. Now, the confirmatory test is a hemoglobin electrophoresis. So when you do an electrophoresis to see which type of hemoglobin is present, you can see that hemoglobin S will also be there. So if it is a HbS trait, you can see that you've got a band near HbS. So this is the normal, wherein you should actually get only HbA. But in sickle cell disease, you will get a band for HBS also. Okay, so hemoglobin electrophoresis is the investigation of choice. So what about the treatment? For treatment, you can give daily folic acid. You can give prophylactic vaccination because you can expect a splenic infarction at any point, which in turn can cause other infections. So that is why you can have prophylactic vaccination against them. Proper rehydration. Why? Because dehydration will stimulate or precipitate sickling. So the patient should be adequately rehydrated. Oxygen therapy to avoid hypoxia, again to prevent a trigger. And the treatment of choice is exchange transfusion. That means you are going to remove the sickle RBC and replace them with the normal red blood cells. Okay, so that is the treatment of sickle cell anemia. Actually, there are also drugs that can improve the sickle cell anemia, which I think is not that important at a first year MBBS level because you are not learning in the name of the drugs, but there are drugs that are available for treatment of sickle cell anemia. Okay. So next we will move on to our next hemoglobinopathy, which is thalassemia. So thalassemia is also called Mediterranean anemia. Here the defect is in the synthesis of the alpha and beta chains of HbA. So the hemoglobin is normal, but the alpha and the beta chains are abnormal. So there are types of thalassemia in which the alpha chain might be affected and there are types in which beta chain might be affected. So alpha thalassemia means when alpha chains are not synthesized properly, whereas beta thalassemia means occurs when beta chains are not synthesized properly. Okay, so either way, the hemoglobin per se is normal, but the quantity is affected. So we can further classify each of these types of thalassemia. So for this alpha chain, actually there are 4 genes that are responsible for the proper synthesis of alpha chains. So based on which all genes are present, based on the severity of the decrease, you can further classify alpha thalassemia. So suppose if just one gene is deleted, then that person will be a silent carrier because they may not have any typical symptoms. Now suppose 2 genes are affected, then you can have alpha thalassemia trait. So they might have mild anemia. Then we've got hemoglobin H disease in which all 3 genes have been deleted. So you'll have moderate to severe hemolytic anemia. So that is called hemoglobin H disease. And finally, all the 4 alpha chains are deleted, which means they might have only just 4 gamma chains because it occurs in the fetal period. So that is called hydrops fetalis or hemoglobin with hemoglobin bars. So in this, the 4 genes are deleted and usually it is typically fatal, so that the patient will the fetal will die in utero. Okay, because the oxygen carrying capacity is too low as all the 4 alpha genes are deleted. So based on severity, you can have a silent carrier, alpha thalassemia trait, hemoglobin H disease, and hydrops fetalis. Similarly, for beta thalassemia also we can further classify it. But the only difference is that for beta chain you've just got 2 genes. So if one gene is affected, you can have beta thalassemia minor. And if 2 genes are affected, you can have Cooley's anemia or beta thalassemia major. So remember this term, Cooley's anemia is the beta thalassemia major. So in this, there is no beta globin production, which can lead to severe anemia. So you'll have to transfuse blood in order to survive. Okay. So that is about the classification of thalassemia. Now we'll see further about why is there anemia in such conditions. So we know that here there are abnormal globin chains. There are no proper globin chains that are synthesized. So thus they will precipitate in the red blood cells, reducing their production. So in the hematology, you can see that the cells are all hypochromic, which is pale. It is microcytic, small RBCs with target cells. See, these are the target cells which contains that dot inside. And when we check the iron and ferritin, see when we see this picture, because it is microcytic and all, we might think that it is iron deficiency anemia. But then when we check the serum iron and ferritin levels, all that will be normal. So what will you do? When there's severe hemolytic anemia, you will have to use repeated blood transfusions because the person cannot synthesize normal RBCs. You will have to give repeated blood transfusion. Now this can cause an iron overload, and which in turn will cause hemosiderosis. Hemosiderosis means iron accumulation in the tissues. And because there's a lot of hemolytic anemia, there will be extramedullary hematopoiesis which can lead to spleen and liver enlargement. And when it occurs in children, it can also cause growth retardation. So these are the clinical features of beta thalassemia. Can have iron overload, hemosiderosis, spleen and liver enlargement, and growth retardation. So how will you diagnose? You can do a complete blood count as well as a peripheral smear which shows this microcytic hypochromic anemia. And the peripheral blood, you can see target cells, nucleated RBCs as well as basophilic stippling. And when you do a hemoglobin electrophoresis, you can actually see which globin chain is absent, whether it is alpha or beta. Right? And how will you manage such a patient? Again, you will have to give repeated blood transfusion. You will have to supplement folic acid for that erythropoiesis, and you will have to give drugs to decrease the iron overload. So in thalassemia patient, the major problem is this iron overload. So you have to give drugs to decrease the iron overload. You can do a splenectomy so that whatever RBCs are there is not destroyed, and you can give a bone marrow transplantation to enhance the production of RBCs. So thus we've seen what thalassemia is, what is the classification, its pathology, clinical features, investigations and management. So now, just to consolidate the different points that you've heard just now, we'll just see a scenario. So this is the clinical scenario. A 22-year-old man with a history of sickle cell anemia presents to the emergency department with severe pain in his lower back and chest. He reports that the pain started abruptly while playing basketball. His temperature is this much, blood pressure is this much, heart rate is this much, and the oxygen saturation is this much. On physical examination, he is in significant distress, but no signs of respiratory distress. His sclera is ectric and there is tenderness to palpation over the lower ribs and back. A CBC shows hemoglobin of 8, reticulocyte count of 12 and an elevated bilirubin level. See, in this case, already they've given the diagnosis as sickle cell anemia. But what is this presentation in the emergency department? What has caused the severe pain in the lower back and chest? Most probably it will be a vaso-occlusive crisis, right? So let's see the different questions that can be asked from this MCQ. Sickle cell anemia is due to, as I said before, it is a point mutation. See, instead of that amino acid, the adenine and thymine gets interchanged, and this instead of glutamic acid, you've got valine in the 6th position of beta chain is a point mutation. And what is the inheritance? It is autosomal recessive. It is autosomal recessive. And what is the most likely cause of the patient's symptom? As I said before, it could be a vaso-occlusive crisis. Why can't it be acute chest syndrome? The symptoms are different. Here in vaso-occlusive crisis, you've got the typical pain which has made him come to the casualty. Then why do red blood cells assume a sickle shape in sickle cell anemia? What's the cause? Polymerization of deoxygenated hemoglobin S. Okay, all others are wrong. And which of the following factors can exacerbate red blood cell sickling in sickle cell anemia? It is hypoxia. So see, there is an option here called use of hydroxyurea. What is hydroxyurea? Actually, it is a drug which we give in sickle cell anemia because it will favor production of hemoglobin S. It will decrease the sickling of RBCs. So hydroxyurea is actually good for sickle cell anemia. Okay. So that these were the questions of sickle cell anemia. Next, we'll see another clinical scenario. Here, a 4-year-old boy is brought to the clinic with his parents due to fatigue, poor growth and pallor. His parents mentioned that he has required multiple blood transfusions since infancy and his abdomen seemed distended. On examination, child has pale conjunctiva, hepatosplenomegaly, mild facial deformities including frontal bossing. The blood work reveals a hemoglobin of this much, mean corpuscular volume of this much, and peripheral blood smear showing target cells. Hemoglobin electrophoresis reveals elevated hemoglobin F and hemoglobin A2 with absent hemoglobin A. So what could be the diagnosis? Why have they, see, initially they've said they've got a poor growth, pallor. Then again, the next key point is that he's required multiple blood transfusions. He's got pale conjunctiva. He's got bony deformities. On examination, he's got anemia. he's got it is a microcytic anemia. Okay, and on electrophoresis here they've said there is hemoglobin F, hemoglobin A2 and no hemoglobin A. So what does that mean? Hemoglobin A contains 2 alpha and 2 beta. Hemoglobin A2 contains 2 alpha and 2 delta, which means the alpha is normal but beta is affected. So what is the most likely diagnosis for this patient? It is beta thalassemia major. What is the pathophysiological mechanism behind this patient's skeletal deformities? Why are they skeletal deformities? Because, is it due to vitamin D deficiency? No. Is it due to increased bone marrow activity due to chronic hemolysis? Sort of. Expansion of erythroid bone marrow due to ineffective erythropoiesis? Well, that is the correct answer. There is an expansion of the erythroid bone marrow due to ineffective erythropoiesis, and it's not due to hypercalcemia. Was the most likely complication from repeated blood transfusion? This is a direct question. It's an iron overload. Okay. So thus we've seen how a clinical scenario of thalassemia and how a clinical scenario of sickle cell anemia would look like. Okay, so thus we've seen about sickle cell anemia, what is the pathology, what are the different investigations, clinical features, treatment. Also about thalassemia, what is the different classification, pathology, clinical features, diagnosis and management. So I hope this video was useful for you. Thank you.